Professor of Psychiatry and Director of the Psychiatry and the Law Program and an Associate Dean in the School of Medicine. And today I'm pleased to introduce our grand round speaker, Dr. Nathaniel Morris, Dr. Ned Morris. Just wanted to mention that there'll be a question and answer session starting at 9:20 a.m. and please submit questions via the public chat box. So let me tell you about Dr. Morris. Dr. Morris is a rising star at UCSF. He received his bachelor's degree from Cornell, magna cum laude. Then he went to medical school at Harvard. He did his general residency at Stanford, where he was chief resident. I understand from Dr. Hung, we tried to recruit him here, but he chose Stanford. But he came back here as a fellow in the forensic psychiatry program. At the end of his fellowship, he was once again heavily recruited for many positions, including at Stanford. But fortunately, he decided to stay here, and he's now working. He's an assistant professor, and he works in the San Francisco Jail Behavioral Health Services. Dr. Morris has received many awards. He's received research awards in psychiatry and the law. He received this very prestigious Rappaport Fellowship. He received an award from the American Society of Addiction Medicine, and he has many publications. In fact, 50 peer-reviewed publications since 2014, and in 2021 alone, he has 13 papers, including papers in Lancet Psychiatry and Psychiatric Services, and JAMA Internal Medicine, in the Journal of General Internal Medicine, and in the Journal of the American Academy of Psychiatry and the Law. You know, as you might imagine, Dr. Morris writes beautifully, and he's also written a lot of public opinion pieces that have been published in the New York Times, in the Wall Street Journal, and Scientific American, and in the Washington Post. So today, Dr. Morris is going to be talking about mass incarceration and mental illness, rethinking the front lines of US mental health care. And you'll see why I say Dr. Morris is a rising star in our department. So thank you, Dr. Morris.
Thank you, Dr. Bennett. Yeah, way too kind of you. I'm gonna screen share. Someone just shout or something if you can't see it. But yeah, my name's Ned Morris. It's really a honor to be here to talk with you all today. And as Dr. Binder mentioned, going to be talking about mass incarceration and mental illness. And what I have really come to believe is one of the defining issues of our time in mental health care. As Dr. Binder mentioned, I recently started working in the San Francisco Jail Behavioral Health Service after finishing fellowship. This is really a topic that you could get a PhD in. You could spend years studying or writing books about. And so since we only have about 50 minutes or so, I'm just going to dive right in. And if people are typing things during the talk, I am even this far into the pandemic, not skilled enough to multitask in terms of lecturing and monitoring the chat. So I'll look into that towards the end as well. So we'll get going. I do not have any commercial relationships to disclose other than, as I mentioned, working in the San Francisco jails as a faculty member. And as we get going, I just wanted to start with this essay. This was a essay that I came across a few months ago by Dr. Elizabeth Ford. And she was one of the chief of psychiatry in the New York City jail system. And this was an essay she had written about her experiences, where she said, "Now when I talk to medical students and residents, I have the perspective of someone who has ventured into the secret spaces where society puts the people we fear." And I think, in medical training, in mental health training, we often don't talk about jails or prisons. We don't talk about these places or the effects that they have on people. And today I want to, just in kind of a brief introduction, bring you into these secret spaces so that you get a better sense of what is happening across the country and also to our patients as well. Learning objectives. I hope by the end of this talk, you'll be able to describe trends in incarceration, including the effects on people with mental disorders and substance use disorders, be able to talk about or outline opportunities and challenges in correctional mental health care. And then probably the most important, I would say, is the last one, particularly for mental health professionals, but identifying ways in which you, listening to this talk, can influence the trajectory of mass incarceration and the care of people who experience incarceration. Here's our outline. So we'll talk about mass incarceration in the United States. We'll talk a little bit about incarceration and mental illness, what mental health care looks like in these settings. And then the main part is basically rethinking incarceration as a front line of mental health care. And even in my title, as I've talked about Frontlines, there are many front lines of mental health care, emergency departments, clinics, ambulances, hospitals. But again, I want to emphasize that I have come to the opinion that correctional facilities are really among the front lines, ranked now among the front lines of mental health care in this country, and something I think we need to pay a lot of attention to as a field. So let's start with mass incarceration in the United States. This is a slide from the Prison Policy Initiative, and it kind of gives a broad overview of incarceration in the country. I think it's important to look at the different types of correctional facilities. So for instance, local jails, you can see state prisons, federal prisons and jails. So there are different levels in which people might be incarcerated. But if you look at this slide, I just want to really kind of focus on jails and prisons. They're often kind of conflated in public dialogue, or people just kind of throw out they were in jail or prison, but they can really mean different things for people. So I actually didn't know this through most of my medical training, but jails, for instance, are typically where people who have been accused of a crime, but may not have been convicted of a crime. So kind of before trial or before plea bargains or anything like that, and are often too poor to afford bail, are basically held while waiting for the criminal process to kind of play out or adjudication. Prisons, on the other hand, are typically where people who have been sentenced and convicted are sent. And you can see here in jails, some people who are, if they're sentenced to like a year or less, the courts may say, or like they may just stay in the jail, they finish out their kind of year and then are kind of released then. But prisons often are for people who have been convicted and sentenced to like a year or longer, which could go all the way up to, life, the death penalty. And so that's kind of a key distinction. And if we think maybe from a healthcare mindset, a difference might be jails are kind of akin to an emergency department, rapid turnover, lots of people coming in and being released. Prisons might be more equivalent to kind of a long-term care facility where people might be there for years at a time. And if you look at this snapshot, it looks like prisons are the bulk of people who are incarcerated in the country. So something like 1.4 million or so versus only about 600,000 or 700,000. But again, this is kind of a cross-sectional snapshot. You have to, again, think of that churn. And so jails actually have something on the order of about 10 million or so admissions or bookings every single year. And so I think that's one thing to think about, kind of that constant churn in jails versus kind of long-term but large prison population sizes. So if we look at how these have changed over time, this is again just the prison population, not the jail population, but through many decades, there's kind of slow increases in incarceration populations, fairly steady. And you see this kind of massive exponential increase in the late 1970s, 1980s. And this is attributable to many different factors. Mandatory minimum sentencing, drug laws, tough on crime policies, 3 strikes, things like that, were basically a huge explosion in our prison population across the country. And you can see peaking in recent years. And now in the last few years, there's been a little bit of a plateau, if not a decline. And so once again, as I mentioned before, this is just looking at the prison population, but jails still every year, something on the order of 10, 11 million people being arrested and booked, or 10 or 11 bookings. Million bookings. And so I think it's important to keep that context that it's, mass incarceration is not just people who are in a prison right now, but it's also the experience of people being arrested, temporarily held, and released. You might have been thinking, well, maybe the population's increasing. Maybe that's a reason why we have larger population sizes in jails and prisons. And so that could be one small factor, but really the United States is quite disproportionately out of step with other countries, particularly kind of peer nations. If you look, we're much higher incarceration rates. This is a little bit older data, 2012, 2013, but compared to Russia. If you look at similar countries, Canada, we're almost 6 or 7 times incarcerating. This is per 100,000 people, so kind of controls for population size. If you look at Germany, so another very large country, so almost 10 times as many people in the United States. And so what you can see in this slide is that we are vastly disproportionately incarcerating people compared to most countries in the rest of the world. This was a survey that was published in 2019, data where they estimated that 45% of people in the United States have an immediate family member who has ever been incarcerated, such as a parent, sibling, spouse. And we'll talk a little bit about racial disparities, which are obviously such an important topic when we're talking about mass incarceration, but something on the order of 63% of Black people in the United States have an immediate family member who have been incarcerated, but rates are also quite high for white and Hispanic people as well, 42, 48%. So this slide comes from the Sentencing Project, and they took data here from the Bureau of Justice Statistics. And one thing that is kind of important I want to point out is, so this is people who were born in 2001. This was in 2001 at our incarceration rates at that time. So again, as I've shown, it's kind of changed and kind of leveled off since then. But for people who were born in 2001, at that time, this was the lifetime likelihood, if incarceration rates continued, that they would end up in prison. And so you can see for all men, 1 in 9, all women, 1 in 56. So there's pretty large disparities. Men are typically more likely than women, but the racial disparities are fairly, I would describe as mind-boggling. You see Black men, 1 in 3 likelihood of ending up in prison in their lifetime. You can see Black women, so 1 in 18, so significantly different compared to white men and women, and then also Latinx men and Latinx women as well, being much more likely to be incarcerated. And so again, a theme of this talk today will be how, in my experience through medical training and mental health training, a lot of this was never talked about. And I want to go through why I think this is so important for our patients to think about the likelihood of them being incarcerated, but also what that means for their lives. In recent years, there's been some evidence to suggest some of these disparities are getting a little bit better. However, this could just be because in general, correctional populations have declined to some degree. And so if you look here, these are incarceration rates, prisoners per 100,000 adults. And so you can see a little bit of a decline in the disparities. However, even if you still look at 2018, I mean, orders of magnitude difference between people in this Pew Research Center slide, they're labeled as white, Hispanic, or Black. So we see profound racial and ethnic disparities in terms of who is being incarcerated in this country. So that's a very quick overview of mass incarceration. Next, I want to talk about incarceration and mental illness. And many of us have heard in the field about people with mental illness and why they might end up in a correctional setting. And so, for example, if someone's experiencing a mental health crisis in the community, what options do we have to call? We often don't have enough community services. People are left really only to call police or 911. And so that may be one reason people end up in the criminal justice system or criminal legal system, because if they're experiencing a crisis in the community, then we have law enforcement sometimes responding. People might get arrested for what are so-called quality of life crimes, so disturbing the peace, trespassing, disorderly conduct. There are also many other structural factors that contribute, such as people with severe mental illness being at greater risk for poverty, homelessness, other factors that increase their likelihood of incarceration. So why don't we go through and look at some of the statistics here. This is a systematic review of state prisons. So again, always keeping in mind the difference in jail and prison populations. And looking at this here, you can see that basically, every single mental disorder kind of listed here tends to be higher in the prison population compared to the general community. So bipolar disorder, major depression, generalized anxiety, mania, obsessive compulsive disorder, PTSD, schizophrenia, serious mental illness, so tend to be higher in essentially or most studies tend to be higher mental disorder rates in prisons than in the community setting. One that was a little odd here is any mental illness you might see. It looks lower in the prison population in general. The author hypothesized that could be because the community samples might have also included substance use disorders in that as well. But in general, just keeping in mind, tend to be higher, if not significantly higher, in correctional populations. This was a report that came out from the Treatment Advocacy Center in 2016. And they estimated that somewhere on the order of 15 to 20% of people in jails or state prisons in the United States have serious mental illness. And kind of crunching the numbers there would estimate that 10 times more people with serious mental illness are behind bars or in jails or prisons in the United States than in state psychiatric hospitals. And so if you look at this graphic here, basically we think about, for every one person who we have in a state psychiatric hospital, 10 of them would be behind bars, incarcerated with severe mental illness. And so that's, again, a profound disparity, and it's something that I think we'll talk about later, how I think as a mental health field, we can do more to think about what does this mean for our patients, that this is where they're living and being incarcerated and getting care or not. And this was a quote that was often or has often been cited since that report came out, where they say, the Los Angeles County Jail, Chicago's Cook County Jail, or New York's Rikers Island Jail Complex each hold more mentally ill inmates than any remaining psychiatric hospital in the United States. And so again, going through that theme where in mental health or medical training, we often think about academic medical centers, universities, large hospital systems. These are in many ways the front lines of mental health care. But I had never in my training until kind of late in medical school learned or realized that these are, so right here to the left, LA County Jail, Twin Towers. You've got over here to the right, Chicago's Cook County Jail. And then down here, this is Rikers Island in New York City. These are the largest, thought to be largest psychiatric facilities in the country. And these are all jail complexes here. I've focused a bit on mental disorders so far, but I by no means want to overlook the profound role that substance use has to do with incarceration, not only in people being arrested, which we can talk about later, but also in terms of comorbidities or co-occurring substance use disorders affecting people's lives. And so this is a little bit older data, but from the Bureau of Justice Statistics. And what you see here is the general population. Somewhere on the order of about 5% of people might meet what used to be substance abuse or dependence is what it's called. But you see here in state prisoners and people in jails, anywhere between 40 to 60% of people. So just orders of magnitude larger prevalence in terms of substance abuse or dependence. Suicide, also a major problem that people we face in correctional facilities for multiple reasons, not only the higher rates of mental disorders, substance misuse, but also just the experience of incarceration and how challenging that is. This is an international study from Lancet Psychiatry looking at different countries, and you can basically see pretty much universally there are significantly higher relative risks on the orders of multiple factors, increased risk of suicide. So this is on the left here for men in the United States, so 1.6, so almost double the risk population. And then here on the right, you see for women, 3.7, so almost 4 times the relative risk compared to the general population. And so again, just going through mental disorders, substance use disorders, suicide risk. I also don't want to overlook general medical conditions in terms of people's health. This looks at people in federal and state facilities, as well as incarcerated people in jails. And then on the right column here, you can see the US population. And for pretty much most of these general medical conditions, it's pretty uniform that people who are incarcerated tend to have higher rates of these kind of chronic medical conditions. So if we look at diabetes, if we look at hypertension, if we look at asthma, HIV infection. And so I think it's tempting to just look at mental disorders, kind of one thing, but I think thinking in terms of overall, burdens of health, but also burdens of illness, thinking about the profound challenges that our patients can face who are incarcerated and what that means when they're released from incarceration as well. And so there are many studies looking at long-term health effects of just being incarcerated, and we'll talk about that more a little later. This was one study that was published looking at people who were in New York State prisons, and also looked at basically various demographic tables for life expectancy. And according to this study, they estimated that for every year that someone served in prison, it decreased their life expectancy by 2 years. And so again, I think that is very, very important for us to think about as health professionals. What are the effects of incarceration, not only on a population public health level, but for our individual patients? And so for each year that you're in prison, estimated to have 2 years less in terms of life expectancy. That goes beyond just the experience of the person who's incarcerated, but also the community around them. This was a recent study released about just exposure to having a family member being incarcerated. And if we think about distress, loss of income from potentially a parent, we think about separations of family members. There are just so many different ways in which incarceration can affect families and communities. And these authors used well-being estimates and modeling to basically, they estimated that any family member incarceration was associated with a 2.6-year reduction in life expectancy. And so again, I think beyond just the person who's being incarcerated, these can be profound effects throughout communities and in families as well. So kind of broad overview of mass incarceration and looking at the interactions of mass incarceration with mental illness. What does it look like for mental health care in correctional settings? And that's what I want to talk about a little bit next. We'll talk about first some opportunities for providing care. And I, in some ways I'm hesitant to go through that because, in my experience, in the majority of cases, incarceration is a traumatic experience for people, which can really be detrimental to their health and can be really difficult from a mental health standpoint. But in some instances, there are cases where people who have never had access to mental health treatment, who have never been evaluated, who have never had opportunities to get referred into additional care, to start medication, to start therapy, incarceration can be an opportunity to connect those people with treatment services and can be helpful in some instances. But again, within the overarching background that I do view incarceration as a generally traumatic and kind of not therapeutic experience for people. I just want to point out that I generally can't take photos at the San Francisco County Jail or at San Quentin State Prison, where I worked last year as part of fellowship. So what I've done is just taken what publicly available news stories and basically examples from across the country, because I do want to show that these opportunities and challenges in mental health care in correctional settings are not just kind of hyper local, but really this is a national phenomenon that we're dealing with in terms of, again, as I mentioned, the front lines of mental health care. This is from Illinois. Here we see a law enforcement officer who's sitting at what appears to be a triage desk. And so if this were to be a jail, someone who is arrested might come in, they might be brought into kind of a triage area. Typically you have a nurse or a social worker, someone like that sitting here, and they have kind of electronic medical record and screening questions. And so those screening questions may go through, do you have a history of psychiatric illness? Do you have a history of suicide attempts? Have you been in the hospital? Are you taking medications? So various screening questions. And then depending on the results, the person may then be referred for treatment. And so that treatment could entail somebody checking in on them again, an appointment with a nurse or a physician, referrals for group therapy. But basically, so this is kind of an intake, triage, and screening area. Many people actually are, if it's in a jail setting, might be on substances and might need additional kind of withdrawal monitoring. Or if this is a prison, someone might have just been sentenced and then kind of transferred from a local jail into the prison setting for kind of longer term incarceration. If you look in the back here, there's a sign that says medical care is available to all prisoners. And so to see the doctor, complete a request slip. And so patients or people who are incarcerated can also submit slips to be seen if they have questions or if they have medical concerns. And we can talk about, sometimes that can be a very helpful way for people to draw attention towards medical staff, towards getting attention. In other ways, that can be really challenging if people are waiting for weeks or months to get treatment that they need. So this is from Salt Lake Tribune. And so if you look here on the left, it looks rather familiar here in a correctional facility where we have an exam room. We have somebody who's in scrubs. Looks like somebody's sitting here maybe on a clinic table, kind of a clinic room with a computer. So this, in many ways, from a medical center perspective, looks quite familiar to us. Then if you look over to the right here, it looks a little different. We have locked doors. This is a theme we'll see in some of our photos, is correctional staff who are kind of watching over patients, right? And Dr. Lauren Roth, one of my colleagues in the jail system, did a great grand rounds last year on the challenges of dual loyalty, kind of our competing obligations to patients as well as correctional authorities or kind of legal law enforcement. And so I'd encourage you all to watch that as well on YouTube. But that's, I think, an important thing to think about is that as patients are waiting for treatment, and there's kind of the semblance of privacy also being kind of monitored and constantly watched in this kind of security apparatus. So in some contexts, people may come for appointments with either nurses or therapists or physicians or psychiatrists. here in kind of a clinic setting. In other contexts, we may actually go out to either the tiers or the pods or kind of to the cells and see people kind of where they are living. If we don't have kind of a setup like this, or if someone has other needs, why we need to kind of go out there. And we'll look at what that looks like in a couple minutes. This here is a photo from, I believe, Massachusetts, where you see incarcerated people here who are receiving buprenorphine treatment for opioid use disorder. And again, just as I mentioned right before, you kind of have this kind of shadow of the law over on the right here, kind of watching over. So again, always kind of thinking about what does that mean for people's privacy when they are being kind of watched like that by kind of non-health professionals, and what are the challenges in terms of privacy and patients' willingness to speak with us. But here you can see is kind of a pill cart. You see a assistant kind of health staff here, a nursing staff member, and in some correctional contexts, there may be a centralized process like this. This is for buprenorphine, where typically people are monitored, but where someone may come to a pill line or kind of an office to receive medications. In other situations, you can see this pill cart is on wheels. People, nursing staff may go out actually, as I mentioned, into the tiers or the cells and basically administer medications to incarcerated people. And in some cases, depending on the prison or jail setting, people may have access to they can kind of hold on a self-carry supply of medications in their cell as well. So mental health units are kind of an emerging trend in correctional facilities across the country. You can see here, this in North Carolina is a mental health unit where they've kind of been structured to be set up kind of similar to either kind of residential or like forensic hospital settings. And this is typically for people with severe mental illness, or sometimes on a voluntary basis where they can volunteer to be there. Sometimes staff really recommend for them to be there. But basically is to mimic a more therapeutic environment for incarcerated people with severe mental illness. And so in these units, you'll have often custody staff who may be more trained to deal with people with mental health issues. They may have a daily schedule that kind of mimics being in a hospital, such as group therapy, yoga, more frequent check-ins from nursing and clinical staff. And this study was released in the last year or two, and I identified over 300 of these mental health units across the country. And so this is definitely an emerging trend in jails and often prisons. This is another example of what might look like, or what a mental health unit might look like. This is in the Albany County Jail, I believe over in New York. And so if you see up here, you can see different kind of military branches. This is a veterans pod where people who are veterans might be incarcerated together. The goal is for more therapeutic effects, where people who are kind of more familiar with each other and their needs. And so you can see kind of a group therapy setting here where different incarcerated patients might have group therapy. As I mentioned before, if people are not at clinic, here's an example where as clinical staff, as physicians or therapists or nurses, we might go out and at people's cells, meet with them either cell front. We might take them to a table like this to kind of chat and have a clinical encounter, or we may bring them back into a private interview room, or if we can, depending on kind of custody constraints, to just have kind of a normal clinical encounter. And so that's what an appointment might look like if we are not bringing someone out to like a clinic type setting, depending on the jail or prison you're in. And so we've gone through several levels of mental health care here, triage and screening, clinical appointments, group therapy, residential units, and many large jail or prison systems now even have their own hospitals or emergency departments. And so these are photos from San Quentin State Prison up in Marin, where I was really fortunate enough to have the opportunity to work last year. And this is a fairly modern hospital building that was built in recent years that has clinic office. It has offices. It has clinic rooms. It has its own inpatient hospital beds. Here on the right, you can see is the emergency department type triage area, where if people have emergency needs, such as self-harm or medical issues, or need to be hospitalized for psychiatric reasons, they might be brought there. And the reason I wanted to include this is, as we've gone through these levels of care, I think you can start to see that correctional facilities are essentially building or making up for the lack of services that we have in the community. And so in the community, it can be very difficult for people to get screened for mental health issues, or to get connected with someone for medications or group therapy, or to get into residential treatment, or to even have an inpatient hospital bed. And so we see these kind of gleaming facilities as correctional facilities, which are in many ways legally obligated to provide these services under often kind of court decisions, but basically are picking up the slack for what we lack in the community. And I think that's important for us to think about. And these are not just kind of random, doctors and nurses and people just kind of practicing whatever in jails and prisons. In recent years, correctional psychiatry and correctional mental health care has really come into its own as its own specialty in recent years. And so we can see here there's a national commission that accredits correctional facilities. So these are standards for health services. They have one for prisons, one for jails. Extensive drug formularies made by pharmacy and therapeutics committees might be in correctional facilities. So this is for the California prison system. And we see here to the right, practice resources, practice guidelines in terms of how to practice in these settings. And so correctional mental health care and correctional psychiatry have really become a kind of pretty distinct subspecialty within the field. So that was, again, a super quick overview, just going through some stages in which people might receive care, kind of opportunities. But what are some of the challenges we face in providing mental health care in correctional settings? So I'll just go over a few of those briefly. You might be aware of these yourself by reading the news, right? You'll see news articles all the time. Here on the left, most inmates with mental illness still wait for decent care. Here's a Washington Post article, federal prisons' dangerous failure to treat inmates with mental health disorders. You can see on the right here in the New Yorker, the jail healthcare crisis and the failings of the criminal justice or the criminal legal system. And so there are many issues that correctional facilities face in terms of providing adequate mental health services, not only just the overwhelming numbers of people who are incarcerated in this country, as we talked about at the beginning. One of the biggest problems we face is shortages of mental health professionals. Many mental health professionals either have not received training about working in these settings, have not thought about working in correctional settings, or really do not want to work in correctional settings. And we'll talk about that a little later on. You can go, this is hrsa.gov, government data website, where basically you can find health professional shortage areas. You can click on correctional facilities because these shortages are so profound that it's its own designation type, and also within mental health. And the last time I had checked, main criteria they used for determining a mental health professional shortage is if the ratio of a psychiatrist to incarcerated people is, or incarcerated people to psychiatrist is 2,000 to 1. And so that's a fairly low bar, but you go through here, and if you click, there are hundreds of facilities across the country with mental health professional shortages in correctional facilities. And so that's a major challenge for correctional facilities to provide adequate services when there are not enough people working in those places to provide those services. And so in many situations, providing mental health care falls onto the shoulders of custody staff or people who are often not as well trained in mental health care. This was one study that was released they looked at about 18,000 people who are incarcerated in prisons. And the key part is in the middle here, the abstract, if you see, where they say in prison, more than 50% of those who were medicated for mental health conditions at admission did not receive pharmacotherapy in prison. And I don't highlight this to say that medications are the be all end all of mental health care, but I do think it's important that for people who were deemed to have such mental illness or mental health condition that they needed medication prior to coming into prison, more than half of them did not receive that treatment when they were there. And so I think that's a pretty profound disparity in terms of access to treatment and what that might mean in terms of if somebody is on a medication that can be life-saving, such as clozapine or lithium, and if they don't have access to that in a correctional setting, what does that mean for their mental health? So I want to go through a few photos of what it might actually look like in a correctional setting. This is a documentary Frontline series from PBS about solitary confinement, or what's more often referred to as administrative segregation these days. And this was in, I believe, the state of Maine. But for many people with mental illness, if they're not receiving treatment, if they've been using substances, if they don't have medications, typical behaviors that in the hospital we might try to treat therapeutically.
And to do at the social level, what we tend to do with the attribution bias is we tend to layer personal judgments, right? So from our own learning history. So this person's the type of person, I've run into this type of person before, I know this type of person, right?
Pretty high security door might look.
And then of course, we're in a world where we also then layer social judgments.
Reinforced steel door.
And so what we tend to
in that room for 23, if not 24 hours a day, and might be able to come out maybe to shower or to kind of briefly exercise. But I once heard someone phrase it as, imagine being in your bathroom for, some people as long as 10 years or something like that. And so I think the profound effects that can have on people's mental health of being kind of trapped literally in a cage or a room and not being allowed out, particularly when what got them into there was already experiencing a mental health crisis. And I think this photo sticks with me as well because it shows the separation that we have from kind of our fellow human beings, right? In terms of these doors in between us. And even as clinical staff, I often struggle when we see people in administrative segregation, where you might have to come, if you see here on the left, and basically the way to talk to somebody is either shouting through the door or through kind of the crack here to the left. And so that is kind of the extent of human connection that people who might be in restrictive housing or solitary confinement might experience. This is a photo from another PBS documentary called The New Asylums, talking about how correctional facilities have become kind of the new psychiatric facilities in the United States. I believe this is a maximum security facility in Ohio. And it may not look like it, but this, if you can believe it, is group therapy. And so looking at this, you can see that literally the patients are not metaphorically in cages, they are literally in cages. And this is a group therapy setting. And again, this is something that I was not totally aware of in medical training or most of my psychiatric training, that this is what, in some places of the country, this is what mental health care looks like when people are incarcerated. And I hope, as I know I'm rapidly kind of going through slides here, I hope you'll be thinking about, what does this mean for people's mental health? What does this mean for us as a psychiatric field? If this, in today's day and age, is kind of what group therapy or what mental health care looks like. And is this what we want? And I think that's something we should think about. Here we have a photo of what appears to be, or sometimes referred to as a cell extraction team. So you'll see either sheriffs or deputy sheriffs or correctional officers basically in kind of this military formation. And what might happen is someone who is either in administrative segregation or in kind of a cell, even if they're in quote ad seg or not, if they are doing something that is kind of dangerous, either threatening staff, flooding their cell, hurting themselves. Sometimes people might put paper over the windows here so you can't see into the cell, so no one knows what's happening. And particularly if someone's mentally ill and if they are throwing bodily fluids or things like that, it may lead, in some cases, trying verbal de-escalation or things like that beforehand, but it may lead to one of these cell extraction teams, and which is basically the goal is to extract someone from the cell and to either send them for clinical care, so to a hospital or something like that, or safety cell, which we'll talk about, or into a punishment setting, such as into administrative segregation or solitary confinement. You can see the person at the front here is holding a kind of riot shield when they kind of charge in. You see this kind of military formation. And from our perspective, where we are looking at this photo, there's often a person holding a video camera who's actually videotaping the incident for liability purposes. Sometimes the team might also use like pepper spray or mace or something like that. And I just want to, again, take a pause and to think about, for our purposes as health professionals, when we think about patients in distress, we think about in the hospital verbal de-escalation, trying everything from using calming presence, having familiar staff members, giving snacks. And I've seen this happen in correctional settings as well. But I hope you'll just think about, if you are incarcerated and you have a mental illness and you are experiencing a crisis, you're not receiving treatment, and this is what might be waiting for you on the other side of the door. And I think that can seem like a pretty terrifying experience for patients as well, and to think about what that might mean for their mental health. I mentioned earlier what a safety cell is. And so this is seen in some jails and prisons. And so a safety cell is basically where someone might be put if they are acutely kind of suicidal or homicidal or really just quite ill, either for one of two goals. One is for temporary safety reasons, or two is if they are, let's say, being put on a 5150, like in California, and awaiting transfer to go to an emergency department or a hospital. You can see it's pretty bare bones, often with kind of soft walls here. And I just want to draw your attention to down here, this little hole. That is typically where people are expected to defecate or urinate. And maybe once or twice a shift, someone might press a button like a custody staff member to then flush that out. But again, I think thinking about how we think about mental health care in this country and what we are providing to people, and this is something that I don't think we often talk about enough in our mental health training, but this is what mental health care looks like in many places in our country, where this is kind of where someone might be put, and again, for their own, for kind of safety purposes. But if this is kind of shocking to you, I think it's something we should talk about more as a community and think about what are the ways in which we provide care to our patients who are incarcerated. And one of the last photos here, this is somebody who appears to be incarcerated who has what's called a kind of a safety garment or a suicide safety smock. And so someone who's put into one of these safety cells might have one of these garments. They might be stripped of their clothing. They might have one of these garments put on. And they're often made from very tough, kind of like Kevlar-like material, where it is extremely difficult, if not like impossible, to rip it or to form it into like a noose. And so basically someone might be put in this outfit so they do not hurt themselves when they are incarcerated. And the reason I thought this photo really stood out to me is because you see in kind of one photo, the mix of quote unquote kind of clinical, so kind of safety purposes, keeping the person safe, this safety garment. And then you see the law kind of where somebody is really has handcuffs around him. And so again, that constant tension between taking care of people with profound mental health needs and at the same time being in this security environment that, as we talked about earlier, millions of people across the country experience every year. So in the last 10 minutes or so, I just want to talk about what are some ways in which we can rethink incarceration as a frontline of mental health care in this country. Particularly for Grand Rounds today, I want to focus on what mental health professionals can do, but I think many of these also apply kind of more broadly. But particularly as mental health professionals, what should we be doing or what can we do to rethink incarceration as a frontline of mental health care? So the first thing I would say is working in correctional mental health care. I think that is one possibility for rethinking incarceration, is working in these settings and bringing our expertise to these settings. This was a MedPage Today article that was written by a physician who works in correctional settings, and Dr. Jeffrey Keller, who said, of course I work in a jail. That's where the sick and needy people are. Why aren't you working in a jail? And I think that was a very interesting essay that I was reading, but I think the point here being that if we go through medical or health training to try to meet the needs of kind of the sickest and neediest people, many times they might not be in our clinics or in our hospitals. Many times they are in correctional settings, in jails and prisons. And so I think that's a very important reason for us to think about working in these places. I worked on this article with a colleague of mine from Ohio, Dr. Sarah West, and we talked about how in training, mental health training, whether it's medical school, residency, or if folks who've gone through social work or psychology training, we often develop these kind of misconceptions about what it means to work in corrections. So this article addresses many of those misconceptions and tries to add nuance. So kind of incarcerated people are less deserving of mental health care. It's more dangerous. There's some data to suggest it's basically just as equivalent, or it might even be more dangerous to work in an emergency department or inpatient psychiatric unit than in a correctional setting sometimes. Less respectable, few teaching and research opportunities. So this article kind of walks through each of these and kind of adds nuance to them. But the one that I still struggle with today is, does working in correctional psychiatry support mass incarceration? And this was an article in around 2010 where they said the medical profession has been complicit in supporting mass incarceration in the United States, despite the many conflicts with the mission of medicine. Prisons and jails cannot be sustained ethically or constitutionally without the support of the medical profession. And I still struggle with this today in terms of, thinking about in facilities like this, where you literally have people who are held in cages or, behind barbed, 23, 24 hours a day. As physicians, as therapists, as social workers, if we are walking these walls, walking these hallways, are we strengthening these walls? Are we lending our expertise and credibility that these are viable places for people to be receiving mental health treatment? Are we strengthening these institutions by providing our medical expertise? And that's definitely something I think about and something I sometimes do worry about. But at the same time, the conclusions I have come to is at the end of the day, not in theory, not kind of just on slides like this, but right now, as we are sitting here talking about this across the country, there are thousands to millions of people who are literally behind bars right now in cages. And to think about what does that mean for their suffering in this very moment? And are there things that we can do about that now? And so in our article, we had concluded that correctional facilities across the United States already struggle to provide adequate mental health services to incarcerated patients. Rather than waiting for mass incarceration to disappear while incarcerated individuals experience widespread untreated mental illness, mental health professionals can use their skills to heal patients with some of the greatest needs and to change the criminal justice system from within. And someone who I think wrote this far more eloquently than I could have is, again, back to Dr. Ford, that essay I brought up earlier. There need to be voices who scream from the inside, who work to alleviate suffering in the spaces that cause suffering, and who bear witness to the displays of human cruelty and neglect that institutions of confinement can create. Psychiatrists can and should represent more of those voices. And I would expand that to all mental health professionals, actually. So we've talked about working in corrections. Next, I would say, is expanding training exposure. This was at least just one survey. There's also surveys of psychology programs, social work programs, but this looks at psychiatry residency programs where they found that 30% had mandatory corrections rotations, 25% had an elective. And I think you can view this in different ways. One way you could view this is, wow, 55% had some sort of opportunity, the majority, okay. The corollary I might view that as is 45%, or about half of programs had no opportunities for correctional rotations. And so I again think about those many people in cages across the country. I think about our kind of workforce development and pipeline of future mental health professionals. And if half of them don't even have any rotations, or about half of them don't have any rotations available to them to see that, to experience that, will they ever work in those settings? What does that mean for patients who have been released from incarceration and how we treat them? And similarly, they found among respondents who are mainly thought to be training directors, just about 1/3 had worked in a correctional facility. And so, training directors of residency programs are often kind of guiding the future workforce development and kind of leaders in our field. And so if 1 in 3 have worked there, if 2 in 3 have not, what does that mean for the what we're emphasizing in terms of the importance of these front lines of mental health care to our future workforce? There are different challenges for setting up correctional rotations, similar to those kind of misconception things we talked about earlier, safety concerns, logistical barriers, but at least one geographically. This was a study that looked at that. It was just a median of 3 miles and a mean of 4 miles to the nearest correctional facility from a psychiatric residency program. Many programs across the country have correctional rotations that I think are really profound experiences for trainees. Actually, proud to say UCSF, I think, is leading in this way and has many opportunities for both medical students and residents to participate in these. Here on the left is a medical student rotation for medical students to rotate with us in the San Francisco County Jail on our team to see patients with us. Here in the middle is a advanced forensic psychiatry rotation, typically for like 4th-year medical students with Dr. Bender, and get to go to San Quentin State Prison. And then on the right here, clinical experiences in the psychiatry residency program, where as interns, people may work on 7L, which is an inpatient jail unit at Zuckerberg, San Francisco General, and then in advanced electives also have the opportunity to come work with us at the San Francisco County Jail. And for those listening, I would highly encourage you, reach out anytime. We would love to have you. And I again think it's really great that UCSF is dedicated to providing these opportunities for trainees. And the 2 reasons people might list for why trainees should have access to these rotations, one on the left is just addressing shortages of mental health professionals. The data is kind of mixed on how much these rotations really recruit people into the field. But that's one possible goal, is okay, maybe we'll have more people work in these settings. But the other on the right here is an article about education, advocacy, and really just even if you don't work in a correctional setting, you will most likely be working with formerly incarcerated people or people who have experienced arrest. And what does that mean as a health professional? If you go into these settings and learn about these things, how can that change your understanding and how you treat people on a day-to-day basis? And I just want to come back to this photo again, because to me, I think it changes something inside of you as a health professional, and at least it did for me, to see your patient in a literal cage. Sometimes in training, we talk in the abstract about important concepts of social determinants of health, housing, income, poverty, systemic racism. We talk about all these social determinants, but I think it's very rare that we see literally in front of our eyes these social forces surrounding our patient. And to think if somebody is in a cage like this, or if we're talking in a crack while they're in solitary confinement or administrative segregation, and to ask, how is your mood? I think that's just such a profound contrast. And to think, will an SSRI fix this situation? And I think seeing this as a trainee, even if you don't end up working in a correctional setting, changes something inside of you and changes the way in which you might treat your patients moving forward, and the ways in which you might manage those social forces in their life or think about them. So the last few things as I wrap up here, so is advocating for reform. One is writing in basically medical journals. So article here on the left where a colleague and I, we wrote about criminalization of substance use. What does that mean for people's well-being and health? On the right here is an article that talks about the public health costs of mass incarceration and arrest regarding cannabis, but also if it's legalized, what are the effects in terms of possible rates of psychosis? And I think these are really important concepts that as a medical community, we need to talk about. I think people can lend their expertise to these debates, conducting research, writing in medical journals and other kind of academic venues. Even if we're not writing in academic journals, many people in the community have never heard of the New England Journal of Medicine or Lancet or many of these journals. And so I think, connecting with the community, these are all folks who have been affiliated with our department, Allison Wong, Matt Hirschritt, Dr. Binder here, writing about, what are the experiences of people who have been arrested or incarcerated, connecting with the public, again, using expertise from a mental health standpoint to talk about these issues. Whether it's not writing in academia, op-ed, this is you could write books, right? People, this is Dr. Christine Montrose from Brown, who wrote a book about the madness of American incarceration. Here is a podcast by Dr. Catherine Warburton, who worked for the Department of State Hospitals, talking about mental health diversion. So I think there are many ways in which we can interact with the public and talk about these issues and advocate on behalf of our patients and kind of broader public health. And even if we're not specifically just doing podcasts or writing books or things like that, is even just engaging in policymaking. And so here we have crisis teams seeing homeless people in distress in San Francisco. So going to supervisor meetings. We have here on the right a basically new federal law about 988 as being a crisis line. So what are the policies that might affect the ways in which people might engage with mental health services and be kind of diverted from incarceration? And just the last couple slides that I have here is talking with patients about incarceration. And so basically, if you say, okay, maybe I don't work with people who are incarcerated, even if you have a busy clinic day today and you're working in an outpatient clinic and see 16 people, on average, about 4 of them will have had a history of police arrest. 1 in 4 people with mental disorders have been arrested. And so what does it mean to talk with our patients about their experiences of incarceration? I think we often overlook these experiences and what it means in people's lives. And so this was an article I wrote about talking with patients about their legal history and how understanding the experience of mental illness in the United States can be difficult without talking with patients about their interactions with the legal system. And so I encourage us to connect with them more on that level. And so just the last closing thoughts, because I know I'm running short on time and want to open up for questions here, is just 2 quotes that have really stayed with me in the last year. The first is during the lockdowns and the pandemic, I was reading The Plague by Albert Camus, which is a book about a town that experiences a plague and is shut down and people are dying. And with COVID, this is particularly poignant, I think. And here's a quote: "For though some prisoners are kept solitary, a prison forms a sort of community, as is proved by the fact that in our town jail, the guards died of plague in the same proportion as the prisoners. The plague was no respecter of persons, and under its despotic rule, everyone, from the warden down to the humblest delinquent, was under sentence. And perhaps for the first time, impartial justice reigned in the prison." And so I think that is a profound statement about our shared humanity. And when we think about masks and vaccines and our separation from people who are incarcerated between these doors, I think COVID-19 really does remind us of our shared humanity with the people behind those walls and how we are not really so different, and really they are us. And the last quote as I finish here is from Brian Stevenson, who is a well-known attorney who's worked with indigent and minority defendants, particularly people on death row. And he has said that each of us is more than the worst thing we've ever done. And that is something that has stayed with me when I take care of patients in correctional settings that I have found to be particularly important in this work. And so I hope that this talk at a minimum has shown to you that correctional settings are really among the front lines of mental health care. And I hope I've inspired you in some way to think about these settings and how we might, as a mental health community, pay more attention to them and change the ways in which people get mental health care in this country. And so just a few thank yous here for the San Francisco Jail Behavioral Health Service, Dr. Roth and Eisenberg, psychiatrists on our team, some mentors from mine from San Quentin State Prison, as well as the UCSF Forensic Psychiatry Fellowship. And in case you brought a microscope, here's the reference list, if you can see those. But really, it's been an honor to speak with you today. And I'll stop the share because I know I've gone a little bit over and happy to answer questions.
Ned, thank you so much. That was such a terrific presentation. And you said that when medical students, residents, other health professionals go on rotations, it changes something inside us. I think that your presentation has changed something inside of everyone who has listened to you and watched this presentation. So thank you so much. There are a lot of questions in the chat. I'm going to try and pick a few of them for you to comment on. There were a couple of comments with the question about what happens with mental health follow-up when people are released from jail or from prison. The person who wrote the question pointed out that in jail, there's shorter stays compared to prison, and you're just letting the person back out into the community, and they wanted to know, do overdoses go up and other mental health crises? And then the person who wrote about the prisons pointed out that after state prison, when someone is released from state prison, they're often given 30 days of medication, and then they're given a referral to whatever their mental health community clinic is. And what happens to those people? And do you have recommendations for that?
Yeah, if we have another hour. So that's a huge question, a huge problem in correctional settings is reentry planning, not only due to the lack of community services and reasons why many people end up incarcerated in the first place is it's so challenging for people to get access to care, but also, the challenges are quite different in jails and prisons. So in jail settings, like where I work in the San Francisco jails, the churn is so quick. I think Dr. Roth, where we had talked about somewhere on the order of like 60 to 75% of people might be released within 7 days. There's so much turnover that reentry planning can be quite challenging. And in some cases, people might be brought to court at 6 in the morning, 7 in the morning, and the judge says, okay, I'm releasing you, and they're just cut loose. And so I think that's a big challenge where at the same time, what can we do to help people, providing medication supplies when we can, providing people with lists of discharge resources. We are often try very actively to coordinate with outpatient providers as well, because I think in my training, there often just seemed to be this kind of iron curtain of medicine where we don't talk to people in correctional facilities from the community. And I think that's important. Prisons are a little bit different where sometimes people might have a release date months or years in advance. And a lot of that preparation that at least I saw at San Quentin was people really preparing for re-entering the world and what that means for them, right? And so there may be more opportunity to maybe set up some of those supports, but again, very unique challenges. If somebody has been incarcerated for 40 years, what does that mean to be out in the community again for the first time when someone has a life inside of a correctional facility? And so I think that there are unique challenges to both environments. And I think that's a really great question about how do we set people up for success? Particularly, I think the question included risks upon release. There's such higher risks of overdose, of relapsing to substance use, falling into homelessness, things like that when people are released.
Right. Another question was, are there statistics to show how likely it is for inmates to request medical care for psychiatric matters when they're incarcerated?
That's a great question. Not off the off the top of my head, I don't have like what percentage of people are requesting services. But yeah, as I had mentioned previously in the slides, the kind of estimates that anywhere between 15 to 20% of people having some degree of serious mental illness, there are huge service needs where I could whoever that asked the question, I'm happy to connect with that afterwards. But for instance, California, millions and millions of dollars spent every year, billions of dollars even in the prison system on providing mental health services, recruiting enough mental health professionals. And sometimes it can be staff really notice. Custody staff might point out, hey, this person doesn't seem so good. They're not showering, they're not eating, they might need treatment, things like that. Other times is people, people themselves who are incarcerated submitting slips. And that's something, for instance, in the jail we deal with a lot is we have so many referrals that how do we triage at the first or most critical needs at the start as somebody who is in crisis or needs clozapine or, very, very high need versus if somebody's kind of not sleeping well right now. And, how can we meet everybody's needs, as best we can? And that's absolutely a challenge we deal with.
Another question is on your slides, you showed that there was a slight decline between 2012 and 2019 in the state and prison population. Why is that? What are your thoughts about that, rather than continuing to go up?
Sure. So again, another hour would be great to talk about this. It's such a huge topic in terms of incarceration in the country, and maybe I bit off more than I could chew. But so in recent years, we've kind of seen this plateauing and even decline. And I think there's many reasons for that. One is at local, state, national levels, many policymakers and people have realized that kind of what we're doing is not sustainable. It is kind of crippling to state budgets. It is extremely challenging. It is extremely challenging for communities. And you get this kind of bottom-up pressure from activists, people in the community saying, this is what incarceration is doing to our communities. And then you have kind of top-down where policymakers are kind of looking at their budgets, looking at the size of these correctional facilities and saying, this isn't sustainable, right? And so both of those pressures have led to, a wide variety of changes, whether relooking at mandatory minimum sentencing, relooking at drug laws, thinking about are there better ways to divert people from incarceration? Because in many ways, we've realized that what we're doing is not working. And many of the people who are incarcerated have high recidivism rates, something like 60, 70, 80% of people might end up back in a jail or prison. And so what are the ways in which we can change these incarceration paradigms to reduce the number of people who we have in jails and prisons and keep them well in the community?
Well, thank you so much, Ned. There are a lot of positive comments in the chat. I hope you can see them, including from Dr. Lauren Roth. And people are saying that your presentation was a model for all presentation. So thank you so much. We're going to end now.
Thanks, everyone. Pleasure being with you.